So I'm Kevin Dirksen. I lead the team at the Providence Center for Healthcare Ethics. Some of you may have been a part of ethics consults that have come up at Providence, have either seen me before or maybe when I used to have hair years ago, or other members of our team, whether current. We have a ethicist with a nursing background, Kayla Tabari, as well as a PhD trained ethicist, Sarah Combs, and just started up a fellowship program. So you may at some point get to meet our fellow, Dr. Elizabeth Balskis, who's trained in PhD philosophy from Duquesne. But also there have been center ethicists from before. Maybe some of you interacted with Nick Cochler, now our system ethicist, supporting Providence across the enterprise, or Father John Toohey for you really old timers in the group. But we got a great team, both past and present, and merely stand in a line of folks that have tried to help out when things get complicated in patient care, including in the neurocritical care space or neurosurgery space. So I'm going to talk about a case that it's quite possible there may be one or more of you in the room who had heard about this case or were involved in this case. It's interesting how cases that come our way actually happen to gain some complexity beyond just the ethics of it. And there can be conversations on the ward, in the ICU, in the break room about some of these things. And we'll just make sure we channel those virtues of respect and compassion and confidentiality around any pieces that relate to a direct patient care situation. But I've designed this case with some anonymity for the sort of sake of a more broad dialogue that way. So with that, and again, as Desi read in the introduction, our professional society is not only in bioethics, but humanities. So we'll occasionally try to throw up something that looks a little bit more visually aesthetic, right? Health humanities, medical humanities. So this is a painting, a depiction of Jesus overthrowing the money changers in the temple. And I kind of like this one because sometimes I think that's the role that folks think ethics is going to play in a tough situation, that we're going to come in and, I mean, I think there's a depiction of a whip here, even quite shocking. But we're going to come over and overturn the apple cart, right any wrongs that are occurring, whether by the patient or family or somebody on the team. And in reality, we much prefer kind of this image of trying to offer a space for ethics to be how we can take a moral pause. As one of the faculty preceptors for one of our residency programs in Providence, Oregon, like to describe ethics to the residents. It's the taking of a moral pause, the opportunity to take stock, to reflect on a situation, and hopefully our better selves and not just our pure id, can emerge in how we're navigating a complex situation. But if you're at all interested in this few minutes that we spent together on ethics, I'm not the only one doing one CME a year. There's plenty of other resources out there. We have a pretty robust educational apparatus. You should not have to tell folks on your team to go outside of Providence for their ethics CMEs. We have a whole robust enterprise providing our ethics CMEs free of charge at the Center for Healthcare Ethics. So you can give them our website, providence.org/ethics, or be added to our distribution list to be able to have access to our internally driven ethics education programming at the center, as well as there are plenty of podcasts out there. If the only time you have, like me, is maybe when making an honorary commute across town, did a podcast last year with the Bioethics for the People group that was pretty fun, did a case study involving another ICU vignette, not specifically neurosurgery or neurocritical care, but there are other resources out there where you can get your ethical fancy addressed that way. So again, move from the image of thinking ethics as like Jesus coming into the temple and overturning the temple, the tables and money changers and all that, and try to channel this image of taking a pause, thinking through how we can channel our best powers of reflection, consideration in hearing about the case I'm going to tell you. So the patient in this case study, a little different case study than maybe you're sometimes engaged in, tapping into the ethics side of things, not a clinical teachable moment in the same way that we typically engage as doctors and nurses and allied healthcare professionals. But Lauren in this case study is a 45-year-old woman who has a relatively non-contributory past medical history, does have a history of obstructive sleep apnea and hyperlipidemia, who suffered a PEA arrest in the field, and EMS is called. And eventually, the paramedics get a return of spontaneous circulation after several rounds of CPR. And the patient is brought to the ED after suffering what is thought to be a subarachnoid hemorrhage and was admitted to the neurocritical care unit. Patient is seen both by neurocritical care, obviously admitted to the NCCU, and neurosurgery. And it is felt that there is likely irreversible catastrophic brain injury with a diffuse anoxic brain injury and signs of a brainstem herniation. The clinical and neurological status in the hours, day or two to follow, only confirms the suspicion that we likely have a patient who is dead by neurological criteria. And the recommendation from the consultants, from the primary team, is that the family transition the patient's goals of care from aggressive, curative, some incredible neurosurgical outcome that we sometimes see. You don't call ethics for those cases. I don't wonder why. But from those places where we have a great outcome to a situation where we have a relatively young woman who was relatively healthy with children to we think she may be brain dead. So, this concept of brain death is interesting when we think about how we got to a place of not only determining death by heart and pulmonology function. Goodness gracious, tongue twisted on a Thursday morning, but also by neurological assessment. And of course, why that is because we did things like create artificial respirators, ventilators that can keep the heart through pumping oxygen into the lungs going well beyond what would be naturally the case. And so if we have the irreversible cessation of all functions of the brain, including the brainstem, that would necessarily prevent the opportunity for the body to continue to function, which we have prevented. We have arrested the process of death with life-sustaining treatment. This definition of irreversible coma, as it was first called, dates way back to the 1960s with the convening of what was called the ad hoc committee of the Harvard Medical School to examine the definition of brain death, and came up with this definition that I articulated: irreversible cessation of all functions of the brain, including the brainstem, as representing a place that functionally is the same as if a patient not on a ventilator, not being sustained by life-sustaining treatment, would be on clinical assessment found to be dead by heart and lung criteria. There it is. I should have just done heart and lung, not cardiac and pulmonological. That is obviously an evolution, right? So before the Harvard committee convened and offered this definition, death was, as we might see in the anatomical theaters of old. In my bioethics education, studying in a place like Padova, got to see one of the great European anatomical theaters. They couldn't even imagine at the time that we would be able to suspend the moment of death to, in many cases, use that to rescue patients, but in other situations, put patients in a state of limbo, where we would then ask questions about what is death anyway? How do we assess that? And how do we engage in evolving our clinical paradigms that way? And so if you leave from the 1960s with the definition of the irreversible coma functionally began to be described as brain death, to in the late teens, 2010s, there was the convening of the World Brain Death Project, because there were inconsistencies around how, say, this initial definition of death codified by a group of clinicians, philosophers, theologians, et cetera, came to be operationalized across the country and the world, even as as a valid form of death. And so you have the Uniform Definition of Death Act recognized across the country from a sort of legal edifice around what brain death is, but then you have functional clinical questions about how do we determine that. And it became clear that there were inconsistencies in how death was determined neurologically in different states and different places. How do we have a definition that can adapt to, say, new ways that we can test for brain function and be consistent across the paradigm, and not have situations where we have media reports of patients waking up after being declared brain dead, which of course are situations where our imagination and misreporting start to create a cleavage between reality and the hoped for outcome here. So we've seen in the past several years, leading up to and even past the World Brain Death Project, that there are questions that are emerging like, is consent required for clinicians to make a determination of death by neurological criteria? Reasonable clinical question, reasonable ethical question I could answer. This paper from a couple of years ago written by one of the preeminent health lawyers in the country, Thaddeus Pope, a JD PhD. Or questions more for those of you who might also care for children. Can a parent refuse the brain death examination for their neurologically devastated child? So with that sidebar, let's get back to the case a little bit. I've told you a little bit about how this concept of brain death came to be, that there's some inconsistencies in how brain death has been determined in different places, a project that came together, international project, a working group to try to standardize some pieces. But in the meantime, we have Lauren, who we are now recommending comfort care. There is no neurosurgical option to reverse the trends with this massive subarachnoid hemorrhage with neurological devastation. No neurosurgical options, as I said. So not getting better the few days after she presented to the hospital. Comfort care is recommended. And let's get to now where we're at with the family, who at least initially seemed to generally understand the nature of her brain injury, was seeming to respond in ways with emotion that seemed to offer to us that they understood that this was a pretty devastating situation. And then about 2 or 3 days in, had asked for more time before we confirm that this patient has in fact died. More time, maybe generally early on, with also concomitant signs of understanding, getting the prognosis, maybe makes some sense. But the requests for more time soon become a demand not to proceed with the apnea test, which sort of stands in the way of the presumed status of this patient being likely brain dead to actually declared dead by neurological criteria. And upon questioning why do you not want us to do this test, they understood that the patient was likely to be declared dead, and then you would be turning off the ventilator. So they were putting some pieces together here about the natural sequence of events. Not being ready, and some in the family having a hope for a miracle. Some were citing a deep and abiding religious faith. They were using this objection to proceeding with the apnea test as a way to stand in between the outcome of if she were to be declared brain dead, which is to stop the ventilator. And they began to identify, well, our goal is to give more time, and we understand that might not happen in your critical care unit at your hospital, and we would like to explore the process of transferring her to our family's native land of origin in Southeast Asia. Unsurprisingly, we now have a team who maybe has some questions about where we go from here, some distress. Hopefully I've narrated it to a point that you can kind of see the tension. So ethics is called. What's an ethics consult? Well, there's a definition by that credentialing agency that Desi mentioned, a set of services provided by an individual or group in response to questions from patients, families, surrogates, healthcare professionals, or other involved parties who seek to resolve uncertainty or conflict regarding value-laden concerns that emerge in patient care. There's a joint commission standard associated with ethics, kind of an interesting sidebar there. They actually pulled it last year. I don't know if any of you else were encountering places where JCO standards were being changed. They were trying to reduce the amount. People pushed back. Now there's a new ethics standard again. But saying that the hospital must develop and implement a process that allows staff, patients, and families to address ethical issues or issues prone to conflict. So it's actually an accreditation standard. Our hospital policy at Providence defines ethics consultation as a clinical consultation with ethics to help address ethical issues or concerns that arise in patient care. And some pieces that I would offer is an ethics consult at one of our ministries results in a professionally trained ethicist responding to a page. I hope I'm wearing my pager today. Can assist you, someone involved in a patient's care, or the treating team to address an ethical issue that has surfaced in the care of a patient, and usually at a particular moment in time. It's not a theoretical question. It's very acute and concrete for a particular patient. Issues that generate ethics consults can be related to questions of decision-making capacity, futility, consent, surrogate decision-making, disclosure, confidentiality, etc. An ethics consult can involve things like one-on-one conversations with members of the treating team, meetings with the patient, the family, others on the treating team, review of the chart, documentation of our recommendations into the medical record, and assistance with trying to convene a broader dialogue if it needs to involve institutional partners, risk management, hospital administration, legal, et cetera. And we try to think of ourselves and position ourselves not as the ethics experts that you call us and we tell you the right answer, but to help pull together established ethical thinking and try to identify a process that might get us to, well, as one of my ethicists said this morning, not necessarily a good option, but at least not a worse one. And what is an ethicist? So that's what an ethics consult is. So an ethicist, and how I'm able to even put that on that intro slide, really related to the evolution of ethics committees in hospitals, which dated back to here in the Pacific Northwest. There was the so-called God Committee that came to be in Seattle when trying to determine between a teacher, a lawyer, a police officer, who would get access to the newly life-saving technology of chronic dialysis. Or in some of the difficult cases that would enter into the legal sphere, some appellate and judicial writings that these cases are not best responded to at a legal court of law level, but there should be internal mechanisms at the hospital to do some of this work. And so that's where ethics committees really got their start. But it sort of became clear that a committee was not the right mechanism to respond to a situation like this patient's. In particular, the first contact that I received from the attending neurocritical care doc came on Thanksgiving Day. I don't know what likelihood you think of getting an ethics committee to convene on a holiday, but likely, or any committee, likely pretty small. So how do we develop a system where there's a little bit more nimble access to ethics expertise and wisdom without convening a committee in that way? A field started to develop. So there are graduate and terminal degree programs to train, to educate future bioethicists. We at Providence and some other places, I did my fellowship training at UCLA to clinically train ethicists, and are starting to develop things like certification, program accreditation, and emerging standards, like some of which I read to you a few slides before. So, team needs ethics. Told you what an ethicist is, told you what an ethics consult looks like. Let's now do some ethics. So at Providence, we have an ethical decision-making model that we try to use when we are thinking about an ethically challenging situation. And whenever we're teaching, we offer this to our physicians, nurses, chaplains, social workers, others on the team, to think through in the same way themselves. So we don't have like a special ethicist break the box way of thinking through. We use the same tool that we offer in our education. And basically we offer that a response to an ethically challenging situation in the clinical setting can often be well articulated with the asking of 4 questions. 1, what is the honest practice of good medicine for my patient? Or how do we demonstrate clinical integrity here? How can we be dependable to benefit the patient, the principle of beneficence or benefit guiding the way. What is fair to my patient in his or her or their context, the principle of autonomy, respect for patients and their autonomy being prominent. And then finally, how can we be accountable to other obligations, our policies, relevant law, other sources of wisdom, and principles of justice and non-maleficence, the latter being a principle of at least let's not hurt the patient and harm the situation, even if the likelihood of benefit is vanishingly small. So we depict this sometimes if we're doing a live ethics consult to think through a situation on a whiteboard, and we'll draw 4 boxes or spheres of concern as I've depicted them here. Again, identifying these 4 principles as helping lead the way. And the whole purpose of this is to identify a process where we can act with integrity. And integrity meaning to act with dependability, to act with honesty, to act with fairness and accountability. This is a definition that we've modified from the business ethics literature by a theoretician, Laura Nash, who said that the best that we can do in a tough situation is not to ensure a great outcome, because outcomes can sometimes be outside our control, but to act with integrity. And so our decision-making process is kind of designed us to ask questions in a way that outcomes be damned sometimes, at least we know that we can put our heads on the pillow at night to know why we acted the way we did. So it sort of lies behind these principles and those questions I read to you. So back to the question, we have a family that's objecting with the performance of the apnea test as a goal of obstructing the process of stopping the ventilator once the patient is declared dead. And there are those who have argued in the ethics literature that we should be obtaining consent before moving forward in that way. So I've got a paper here cited from 2020 and maybe a commentary in that latter issue, but there are some in the literature that argue a positive standard for consent in these situations. However, have done some writing ourselves in connection to some of the difficult cases we've encountered, and subsequently there have been others from a bioethics, from a clinical, from a health law perspective. Wrote a piece a couple of years ago over the pandemic with Dr. Judd on how there is a way of arguing that there is a set of responsibilities that occur with the management of ventilator technology for a patient, including things like switching modes and upwardly or downwardly titrating settings. And one basic constitutive function that we have to be able to know when sustaining life with life-sustaining treatment is to know if a patient is alive or dead. And so that necessarily requires things like apnea tests and the like, which had a very good reception. So the World Brain Project, as I said, was trying to reduce some unnecessary variation around standards of determining brain death. And one of the pieces that some of the working group members after the project sunsetted codified in a standard that dropped late last year, a practice guideline, a consensus guideline of the American Academy of Neurology, American Academy of Pediatrics, CNS, I don't know that, Society of Critical Care Medicine. So one of those, bunch of different letters of groups that come together and say this makes sense to us, had offered in response to this question about consent for apnea tests, this recommendation that clinicians do not need to obtain consent before an evaluation of BD/DNC, brain death/death determined neurologically, unless otherwise stipulated by the institution's policy. So does Providence or wherever you practice say otherwise, or there are pertinent state laws or regulations that dictate otherwise, of which are not the case here in Oregon. And I'm not aware that that's the case in Washington either, if we have folks who cross the river for our CME today. So if I'm thinking through this case from an ethics perspective, things like clinical integrity, beneficence, autonomy, justice, non-maleficence, sort of direct us toward thinking that we have a duty to identify our patient's vital status in providing them with the ongoing care they're needing. And in part, that is a constitutive function of life-sustaining treatment, ventilatory management, and that's a core piece that has been argued and was well received in the literature. And that we also have some justice considerations too around the utilization of scarce resources, not just in ways that we want or families want, but that is consistent with our social contract to manage hospitals, to manage ICUs, to utilize life-sustaining treatments in a way that will benefit patients and not be a crude, ruthless manner of experimentation or creating tiers of healthcare where people who will slip a neurocritical care doc an extra $100,000 can keep their patient alive for another week where there's no benefit. So that principle of justice being key as well. So our approach at Providence in a situation like this, and I must say, this is not uniform. So I have heard other ethicists in other parts of the country respond differently, have different policies, different guidance. I hope over time, the consensus guideline that I cited from late last year will start to coalesce a more clear practice around this. The standard of care will shift more toward this, what I hope feels a pathway of prudence in these situations, which is that consent for confirmatory testing for death determined neurologically is not required, with those principles of primarily clinical integrity and beneficence leading the way. And that just because it's not required, however, doesn't mean that we ought not communicate that to a patient's family and loved ones of what we think is the case, what our efforts at determining of doing things in a patient's room, on a patient's person, with a patient's body are for. We should say that we think that your loved one has died, and we're confirming that fact with this test. What questions do you have? And clearly describing that what the plan would be for discontinuing not then life-sustaining treatments, but organ-preserving interventions based upon the sort of duties that we have in those situations. In some situations, we would provide a reasonable period of accommodation for turning off ventilatory support for a patient declared dead, but not in situations, say, when the unit is full and someone alive needs that resource, or there are other competing justice-oriented considerations that mean that that's not possible. I really like this resource that I stumbled upon or someone sent to me out of the nursing literature, talking about, and I've said this numerous times in consults, terminology associated with brain death is confusing to family members because it sets up that this is something different than death that's determined from heart-lung criteria, listening to the chest with a stethoscope. Again, if you think about it conceptually, most families, when you really slow down and explain it, the reason we can't do that is because we have a ventilator that is preventing our ability from measuring whether the heart and lungs would stop naturally on their own. And the reason being is that there's that underlying function of the brainstem that can continue that on if there is functional status there, or if not, that would necessarily mean that the patient would stop breathing, the heart would stop beating, and the patient would then, with that same stethoscope, be found to be dead. So I think when most families are explained that very clearly, they understand that brain death isn't something different. It's just how we're measuring, how we're determining, how we're declaring because of the things that we're doing with the ventilator, with life-sustaining treatment. But would recommend that not be language we use with families. Terminology of brain death is confusing. I'm not the first person to say that, but I won't be the last. So how did this case end up? And then I'll pause for questions for the last maybe 10 minutes or so. So we met behind the scenes. So good ethics starts with good facts, clarifying the patient's condition, situation, prognosis, what options are available, as well as recognizing that in cases like these, if everyone on the team is not on the same page, the paradigm of we're still in football season, right? Monday morning quarterbacking is a thing. And sometimes the best thing to do is delay a day or two to make sure we can get everybody on a phone call and make sure that partners in risk management and administration and legal don't have questions. interestingly, not asking them what to do or asking for permission, but what are the relevant risk considerations that you would have us think about? Are there any particular legal obligations here that we should be aware of? But again, sometimes doing that work beforehand can prevent questions when a family member calls an irate family member calls a out of touch administrator about a situation happening, then creating sometimes a cavalcade of confusion, mismessaging, and the like. So we did confirm the plan behind the scenes, I want to be clear, and decided that we would be communicating that to the family. I myself, as the consulting ethicist and a member of our clinical leadership team, had met with the patient's family to tell them. And we basically had identified that there is a positive obligation to identify whether our patients are alive or dead. We have to do that. Given where we're at, we can delay for a certain amount of time. I don't have the details in front of me, but I think it was 48, 72 hours, something like that. And once the patient was declared dead, was determined to no longer be living, not just some ethical definition that the Ethics Center came up with, but a legal form of death in the United States, that the hospital would then have to no longer continue to provide the organ supporting interventions. And the patient at that point we would proceed with normal decedent affairs and the like. Really try to listen to the family, ask for their understanding, their responses to that, and clearly said, given that little piece that you might have heard me say before, one of their goals was to seek transfer to another context to provide ongoing care for opportunity for recovery, that this would need to start now, that the time is not tomorrow, the time is really today, and to be clear about how we could assist with that process, but it would be primarily on the family to arrange. And I was very clear that I thought that it was very unlikely that they would be able to transfer a presumed dead patient from a neurocritical care unit, not only across state lines across the country, but internationally. And if so, if that was possible and all of the pieces could be put together, that would be extremely costly. Which I don't love bringing money into clinical conversations with patients around goals of care, but I thought it was an important piece kind of around informed consent, that they would understand what the insurance would likely not be covering an international transportation of a presumed dead patient, not only across state lines, the country, but internationally as well. And the family got it. They understood. They appreciated the hospital's clear articulation of what the parameters were, why, understood the timeline, and that there was an attempt to meet them with not necessarily keeping the patient alive on the machines without testing indefinitely, but at least a delay for them to explore what transfer opportunities existed. And I would say that the conversation was fairly collegial and understanding. So the outcome was, I thought, somewhat miraculous. I hate using that with doctors and nurses and patients and families because it gets used in untoward ways, I would argue. But the family was able to goal concordantly, what they wanted to do, not what we were recommending, identify a transfer agency that was willing to accept the case and was willing to transfer the patient under the timeline that had been identified. So there was no need to further push out and threaten, sacrifice our considerations of justice and stewardship obligations around the allocation of scarce resources, but were able to achieve their goal, and they were able to transfer the patient for more time. So the last I heard, which again, nobody calls and updates ethics days, weeks, months after, so others might have other information. For a time, this patient was still living, still the same neurological injury, but never declared dead. And the family continued to seek that time for recovery, which we felt was in their right, even though we weren't going to be the ones that did that, that was within their right to arrange, and so they did. So with that, I'll stop for questions. Yeah.
Before you go, because we can't hear you online at all, and so I want to make sure, if you don't mind.
Oh yeah, I would love to get after it. Okay. So in terms of the
Can you
case study,
tell me what your name is and where you practice?
yeah, heck yeah. I'm Tegan Fortes. I work at Providence, Portland on 8 North, which is orthopedics, but sorry, I wasn't even using the microphone. Which is orthopedics. That's me.
Hi.
Hello. All right. In terms of the case study, did they ever mention what the patient would have been interested in? Also,
Yeah.
if they were going to transfer her, would she not have to be extubated?
No, so the patient was transferred on life-sustaining treatment, was transferred on, I mean, a different ventilator was applied, and they were transferred, the patient was transferred on ventilatory support. Which,
Super intriguing.
Yeah. But your question, though, let me take the first one, if I may.
Yeah, go for it.
So I think that that's probably one of the ethical vulnerabilities in how we navigated this case and the outcome. And I had a situation in the last couple of weeks at another ministry that had some overlays of a patient presumed to be dead, was then found to be dead by neurological criteria. And this patient was pregnant at the time. And there were questions about what are our obligations to continue for this patient who had died, organ supporting interventions for the sake of promoting the life of the gestating fetus. I think it's a great question. And in fact, if one takeaway can be always in surrogate decision making, going to the question of what would the patient want, I think that's a universalizable, teachable moment, not just what does the family want, but what would the patient want here. The ethics literature is interesting on the question of when you have somebody who's died, right? Or somebody who you think has died. In some ways, that ought to still take precedence, right? Because it is that patient's body that we're still talking about, right? And there was another case that we had a long time ago that also involved some themes around this issue of death by neurological criteria in pregnant that I was citing on this case a couple of weeks ago. And the only reason why that there was additional time in that case, some of you may have also heard about that or been involved in that, was because there was a clear sense the patient would have wanted that. But in many cases, we just don't know, right? So how likely is it to talk about, well, if I not only had a terrible clinical outcome, but was actually dead, right? Like actually found to be declared dead, I would want this or that done or not done with my body. The family's sense was, so sometimes you can't get to what the patient actually said, but what they think the patient would want. The family was united in the fact that, at least that I heard, that they felt that if the family, so I'm conditioning this, felt like there was a chance of a good outcome, that she would want them to seek time for them to have closure associated with that. What's the harm, right? No signs of suffering, right? No clear sense that this was a burden on her, like we sometimes do experience when family members are asking more time. They said, we think something's good going to happen, and we're looking at the patient and seeing suffering. Again, with this situation, the patient is unable to experience those aspects, permanently devoid of consciousness, dead by neurological criteria. So they were, I think, able to make that argument in a way that we bought, but there is some vulnerability in that piece because we don't really know how the patient herself would have directed care in these situations. And it's a bit of a leap to say the family's going to step in and they're going to decide to do that for her. We do that all the time, but I would say it's still a gap in our sort of best ethical thinking in these situations. Did I answer your question?
Yeah, definitely.
You have follow-ups?
Yeah, it follows. I would bet $1 billion that they're going to start saving that baby and not caring about it. Sorry, politics. Anyway, final thing, is there like cross-cultural considerations in the guidelines?
Yeah, so it's a good question. I would say aspects of cultural humility, cross-cultural communication, inform kind of our general practices around, not just merely clearly stating what the policy is and running, but that kind of active listening, the empathetic hearing, and trying to closely query why. What are the reasons why a patient, a family member is requesting whatever it is that they're requesting? I would say that in most situations, we do have a sort of situation where a kind of Western ethics rules the day. and that even those principles that I showed you early on of how we think about ethics are definitely steeped in a certain tradition, right? So we try to interpret a principle in that third question, like autonomy, not to just be what the patient themselves, the atomistic individual wants, but sometimes ask questions of relational autonomy. How does this situate within the patient's network, the patient's close relations? How does making decisions work in your family context and in your culture and tradition? But there are certain places in which we kind of run into rough situations where, well, I can tell you how that happens in our culture, but that's at conflict with what the patient's actively saying. And we sometimes have a rub. So at the end of the day, we quite often will default to what the patient themselves would want. And that sort of being an ethic imposed on a family in a situation, even if there's an accurate sense that it would have functioned differently in their context. So I would say we try to ask the question, try to hear where it's coming from, trying to weave that into the process. But at the end of the day, there still can be quite a sense of the individual gets to decide, and our duties around informed consent and refusal of treatment often kind of guide the day that way. But great questions, thanks. And PMC represent.
Thank you. I'm going to pause. Are there any questions online? Didn't think. Okay. Nope. All right.
Hi there. Thank you for the talk. My name is Jonah Wren. I'm a ER and sometimes critical care nurse at St. V's.
St. V's represent. Got to be fair, right?
And I guess I just have a question that is based on, I've had several cases where this comes up. I think it's a fairly common issue that comes up, especially among certain like patient and family populations. And I'm curious if you have a go-to recommendation for clinical caregivers experiencing this kind of feedback when a patient, oftentimes a patient who's non-English speaking, receives some kind of diagnosis and their family is like, oh, we're not telling them.
Yeah.
They're not allowed to know that. And obviously there's like a lot of ethical considerations built into that. And that does have a wide variety of cultural aspects and like family traditions. But also in terms of being able to even have the conversations and in terms of like ethics of appropriate interpretation, which I will be honest, I don't think that are always done appropriately in the hospital, especially inpatient emergency department settings. I guess I'm curious what, if you have any general recommendations to bedside caregivers in those situations.
Yeah, so I'm humbled that you think I'd have great language to offer. That's awesome. I may have sounded somewhat intelligent up here. And that was the analogy that I was also thinking of when responding to your question, is the issue of information disclosure, particularly clinical diagnosis, prognosis information. I could have went there, but then I would have prevented you from asking the question. So I'm glad I didn't go there so you could ask your question. I would say that the field of clinical ethics is more or less settled on this question. But again, you have to come up with the language, right? Because you're the ones that are experts in caring for patients. We're the experts in like reading obscure references and sometimes contributing to references in the literature on this. Is that if a capable patient, so if the patient has decision-making capacity and they have a desire to be active in the medical decision-making process, the patient has a right to know that it is a failure of the informed consent process to let a patient who is actively involved in the making of medical decisions not know what their diagnosis is, what their prognosis is, what the treatment options are. It's sort of handcuffing or worse a patient who's directing care in a way that they don't fully have the ability to understand what they're requesting and why. More nuanced are situations where a patient doesn't have capacity, for instance, or a patient says, well, I have capacity, but I want my family to make the decision. Then it becomes a lot more sort of discernible. And in some situations, we might ask, well, what would the patient want? Say they don't have capacity. They're not involved in the decision-making process. They're asking, what's wrong with me? Not decisionally, they're asking, what's wrong with me? How do we respond to that? I think that there can be some approaches that try to not go into an untoward amount of detail if it's felt like the family and in their cultural context that that's an appropriate way for them to hold that information. But we'll often say we cannot ensure that a diagnosis or a prognosis will be communicated. If they improve and ask in a direct way and we feel like we have that information, we have a duty to respond to and our primary duty is always our patients, right? Sometimes we feel like it's the family that's going to sue us, but we have to be dedicated to the patient's needs themselves, is that we'll say hard things like, we're going to answer their question if asked. So I would say that in many respects, aspects can be settled, but one thing I've also learned is the difference between the emergency setting versus the wards versus we have to be sensitive and nuanced to how these develop and what a patient's articulating, what the family's saying, what is the cultural tradition. Sometimes also culture is used as a, sort of explanation or a justification, and it's more just we're kind of being protective of that as a particular person, and we can think around how can we support that information disclosure in a certain way.